Good evening, good afternoon, good morning. Absolute pleasure to be here with you all and bringing you the best wishes from Mumbai. I'm JP Agarwal from Tata Memorial Hospital. I'm a radiation oncologist with my special interest in lung cancer and also head neck cancers. Want to thank you, Dr. Kamal, Mustafa, Dr. Hai, and everybody really grateful and privileged to speak to you something on my thoughts on target delineation and segmentation. The whole focus is a learning process for everyone, including myself. And we will be more concentrating on the tumor and the target. And for the time being, I am leaving out the OAR, which itself is a big topic in discussion. The whole thrust has been on delineation of a gross tumor, understanding the clinical target volumes, and something on the PTV, because I understand PTV itself is really complex to begin with, but I will touch upon that too. Let me start with my next slide. So, as we all aware, the aim of radiation oncology is to provide a sufficient dose to the tumor or get the target area so that we have a high probability of cure. Simultaneously, it is our business, our domain as a physician that we provide the least doses to the surrounding organ at risk so that they are anatomically as well as functionally competent with a complete cure. So that's the therapeutic ratio what we are seeking for. And you as understand, in a target, we are going to have a very high tumor burden, number of cells. And as we go ahead in a distant area, the tumor burden decreases. So we have to ensure that what we treat is this whole area, okay? And leave behind these areas with no dose or minimal dose such that the normal organs are fully normal in terms of functions too. So as we understand, radiotherapy is a process like a garland, you know. So each, what I say, moti or each bead is important or each flower is important. And it has to be in a very, very systematic fashion. You as a physician see a patient, find out the extent of the disease, you then make a decision to treat. And as well as when you want to treat, at that point of time, you think of understanding that make a patient's, what will be the position of the patient, which has to be absolutely comfortable because the treatment time is going to take a couple of minutes. So the patient should not move. What type of imaging you would like to do, what type of volume determination, what we are going to do it, what treatment planning systems we are going to use, and what doses we are going to prescribe. So treatment verification has to be done before the actual treatment is delivered, and then actually we deliver the treatment. And then again, we go back and again see what we have treated. So technically, that is a complete process what we follow with each patient to find out what has happened to the patient. So today's determination or today's thought process, what we are going to discuss, how we are going to do a volume segmentation. I want you to concentrate on this little bit busy situation. Understand that you come up with a new drug And this is actually which has happened in real life. Let's say a wonder drug, and here this wonder drug was tirapazamine. And this is a head neck cancer study in a locally advanced cancer. And the wonder drug was tirapazamine because it was a hypoxic cell sensitizer. And in a phase 2 trial, unlike many other studies of phase 2, this has really shown a substantial outcome differences. But in real life, what has happened? This whole trial failed. Many phase 3 failed, but this failed because of certain problems of the not following the radiotherapy process. So what was happened in this, that nicely written trial at demonstrating a reasonable uh, pragmatic 10% difference between the test arm of a head neck curative doses of 70 gray with concurrent chemo of cisplatinum, and the randomization was 1:1 with stratification of cisplatinum versus placebo. And difference was sought for a survival. So they inbuilt in the trial a good quality assurance in terms of whatever we plan and whatever we desire to treat, we will actually treat these patients with that. So nearly 800 plus patients, okay, they were subjected to 2 arms. In that quality assurance, so what happened that nearly more than half of the patient, what was planned, they submitted and there was no modification required. In nearly 110 patients, there was some modification. They were not at all submitted. And they were, in that sense, out of these 166, 109 were compliant. These 2 were non-compliant. And in these, there was some modification required, which were unfortunately not made by radiation oncologists. So in nutshell, what I'm trying to say, 208 patients, okay, were technically non-compliant to the planned what we wanted, so that to deliver what we want to deliver and what they actually got. So these are the outcomes. So what do we see? The patients who were compliant had the best outcome. Those patients, even which were made compliant, they had a reasonable outcome. And some rogue who were never compliant and they never were doing their business correctly, they pulled the whole study and this wonder drug down. So what happened? These modern radiotherapies really a complex process. A robust QA is essential. That's what we learned. But if we can teach these non-compliant guys to work in a correct way, we will have the better outcome. But unfortunately, that wonder drug has been almost lost from the system. And I am not sure that we are going to repeat something like this study. Okay. And I want to thank everyone across in these studies, especially Dr. Lester Peters, a giant, a legend, to think a QA, extensive QA in the part of study, to understand that training and to follow the rules of the game are not only vital, but they are essential to have the best outcome. So we've come down to the basic topic of delineation and system. So there are 2 types of uncertainties. One are systematic, one are random. So you can have a good accuracy, but a poor precision. So this is also not great. This is hopeless, and this is never desirable. So if we practice, if we follow the rules, and if we follow the guidelines, believe me, we can minimize or eliminate these systematic errors and uncertainties. Okay, so that we are almost always reaching with a good precision as well as good accuracy. So what I'm trying to say, it's a complex process. A good feedback will lead to a good outcomes almost always. This whole story of segmentation started in nearly early 80s, 1975, 78. And ICRU, I think we must uh, congratulate them, you know. They are the selfless giants, nearly 15 of them. Present chairman, I think, is Vincent Gregoire, and they are said as commissioners. So commissioner is Vincent Gregoire, and he was past president of ISRO and so many other things, and truly a legend in head neck cancer. So in early 80s, they gave a concept of a target volume, though they were doing only 2D at that point of time. And they're planning only on the single slice or a midline area in a head neck. Okay, classically, this was many of us practiced. Still, some of us are practicing. Not bad. But what I'm trying to say, we used to do only one midline cut, like in a chest wall or in this, and we used to plan the doses. But we understand these are the so many inhomogeneities. Now we understand that. And the calculations were always for the co-planner. Somewhere the reference point was the midpoint of this. And the whole idea was to provide an absolutely homogeneous dose to this whole target area. Quite a challenging task. And they were doing simple calculation without inhomogeneity factor, etc., etc. But that's where the ball started rolling. And subsequently, in 50, 62, 78, and 83, which is the recent one, they started making the whole thing rolling that what we are prescribing, we need to record, we need to report. Even they did it for photons, electrons, not only that, protons also, but even for the delivery technique like IMRT. So what I'm trying to say, that these independent members and the commissioner thought very, very diligently. They came out with very succinct report, an extensive report, how we are going to function, how we are going to have intercontinental comparison, inter-institutional comparison, intra-institutional comparison. Okay, so they gave the concept of these target volumes. And what are they? So they gave the concept of GTV, CTV, ITV, PTV, treated volume, and the irradiated volume. And as you can see, this is the smallest one. As you go on increasing, proportionately it increases. To that extent, the gross tumor and the irradiated volume, the differences can be even 5 to 10 times. Okay? But let's concentrate on gross volume. So, gross tumor volume, okay? For a physician, in the old days when they were doing their undergraduate, one of the things where they were taught in the clinic was first to inspect what you see. See it very well, what is the tumor size, where it is, how many are there, and confirm your finding with palpation. It's exactly the same. So the clinicians don't get worried. Okay, you have to review your mucosal disease. And now, like the TNM says, so you have to integrate your radiological phenomena by the extent of the disease as a part of the disease. So whatever you see even in radiology, through the endoscopy, they all come as a part of gross tumor volume. So actually it is a physical volume, okay? It is not a geometrical concept. Similarly, we will deal with the CTV, a clinical target volume. So technically, just to reinforce here and compare with the GTV, it is not visible. You can't feel it. It comes only with someone's clinical experience or some surgical series, or you have radiated a patient for number of patients and you start seeing the failure points. Some areas of failure you have not radiated. So from there, you come out with failure patterns, okay? And there becomes your CTV. And sometimes it is even beyond, okay? Even some things which we can't see. Like there is a distinct differences between the same node, which can be illuminated on a PET, okay, which is less than a centimeter, in like in CT scan, a more big node you can always see, okay, a rounded node with maybe a fuzzy margin. But in a PET, you can even see or check that even the node size is less than a centimeter, but it has lightened up, okay. So that is the beyond what I'm trying to say, a resolution of a simple CT you are seeing on a PET CT. But technically also, what I'm trying to say, the still CTV is a physical volume, unlike your ITV or a PTV. Got my point? So Dr. Kamal has said that I am supposed to give some questions also. So the question is, what is the acronym of GTV and CTV? I'm not sure. He's going to put some quiz or something like that. But let's say, remember those things. So we said imaging. What imaging? Which imaging? What point of time? And which is the ideal imaging? Is it PET? Is it MR? But in some cases, definitely for a oropharynx or a nasopharynx, as a clinician, I'll prefer a MR. But to plan a radiation, because I need an electron density at this point of time for any treatment planning system, so CT scan becomes almost mandatory for me for any planning, barring in some research tools, like can I use MR and do a synthetic CT on that. However, PET has come as a real boon, or you want to use multimodal imaging, co-register them, okay, to have the most appropriate GTV. Let's see what has happened. So in this picture, what do we see? A standard CT scan, what we see, and this is the gross area of the tumor which we have marked, okay? But when we see a MR, probably this is the most visible area which we are going to mark. And what we see, even there is an extension in the contralateral side of the vocal cord. Can you appreciate that? However, when we did a PET scan, when the Jen did a PET scan in something like 2003, and she reported a volume, probably this was the metabolic volume. So on a CTV mark like this, MRI mark like this, but actually when a surgery was performed, so this was the actual pathological disease. So we need to have a good imaging which will represent the real life. Similarly, what do I see here? Let's say a lung, okay? So one of the common challenges why we have not been able to mark the correct GTV inappropriate uses of window. So can you see this window? So this is what my media channel window. So in this Eclipse, okay, I'm Eclipse user, but nothing to meant for that the other users like uh, Monaco is not good or Concentra is not good. Everything has every good planning systems have windowing systems in that. So this is a media channel window, and this is the long window, and we need to have a standardized 1600 window, okay, and a minus 600 Hounsfield unit, so that we can see the parenchymal disease well. But in contrast, what we need to mark is the mediastinal, sorry, apologies. So this was the mediastinal window, and this was my parenchymal lung window. So the window width and the length or the center has to be 1600 and minus 600. That's the AF, right? So here in the mediastinal, it has to be 420. That's what we have standardized. And if we follow this rule, the likelihood that what we are going to mark will corroborate most probably with the pathological size. And probably that is the most accurate way of marking these gross tumors. So there are many studies across the tumor sites, okay, who has marked on CT, CT PET, CT PET MRI, and then they came out with some confidence interval limits that which is the probably the most appropriate in your time, in your tumor area or in your area. But what I will suggest, you have to do your own exercise in your setting. You may follow some guideline, but at the end of the day, you have to work with that, follow those guidelines, and come out with your own area of tumor areas. So we did that on our exercise for some long time. So from somebody is marking, like I am marking and my other colleague is marking, there may be a set of inter-observable variability. No doubt on that. But how to minimize that, that is the key. Okay. So we did this exercise when the Shiv was one of our young postgraduate. Okay. And Tejpal was leading this front along with Sarbani and myself. And what we learned in this, that there is an inter-observable variability when all of us were marking this patient. And the important thing was, it was moderate, or what I'm trying to say, a reasonable limit, okay, between all these three observers, which was much more for the target rather than for the OARs. And how we can minimize this variation was with the use of FDG PET. And there was a significant reduction in the variability in all of us which we drew. Though the variability was not so large, but still there was a variability. Let's see some of the lung ones. So in the lung window, when I wanted to see a tumor, very smooth border, definitely there is a collapse, but I can't make out a tumor. Even in mediastinal window, it was a big challenge. But you see the PET, it remarkably delineated the area which is glowing. Definitely there is some challenges at the edge which are going to be there, but still there will be a considerable decreased inter-observer variation when we will be taking the assistance of PET. And is it a complete panacea for this? Probably no. If you see in some of the next picture, can you see the whole SOL or the soft tissue tumor? But there is a definite extension of the tumor along this fissure area. But though it is not glowing here, okay? So if I mark only on this area, probably I will not be doing a justice. So we need to see in all windows and correctly and appropriately mark these areas. So we wanted to do some PET studies and try to do some auto contouring so that the time is decreased, the consistency improves. So we also wanted to see what is the histopathology size of this gross tumor versus the PET, which will be helpful when we are going to mark for SBRT or any curative lung tumors. What we found that possibly the SUV of 40 max, 40% max, was a reasonably good in agreement when we were comparing the small so around 40% or SUV max of 4 was the best match for pathological side. But can we take this for our auto contouring? Probably we can take it in-house. But is it worth for the whole country? Probably not. There are patient factors, blood sugar level changes from each patient to another patient. The lean body mass changes from each patient to another patient. So we need to do a really large number of patients to see where exactly the SUV matches. Even if I wanted to compare between two centers, probably maybe really I have to work in my center and another center has to do their own studies because the PET machine algorithms, what they are calculating SUV, may have a different algorithm, backscatter, okay, or the background cutoff has been done or not. So what I'm trying to say, just don't follow blindly. Check your systems. Can you do that or you can't do it? So what the PET, is it a complete panacea for GTV? Absolutely no. Maybe a question for Dr. Kamal, which so there are no validated, what is a ideal based tumor delineation? What is that magic line which exists between the normal area versus the target area? So that gray zone, or what we say the orange lit zone, need to be visually checked. Okay, your SUV cutoff or SUV threshold may give you some idea, but a definite visual inspection is required. The another important thing need to understand that the resolution of PET is far poorer than the CT. Okay, maybe 4 mm plus, and also the PET takes some more time than in comparison to CT. So there may be a challenges because of the time delay. And definitely many people will not get a planning CT in their systems to work on this. But definitely PET will help in inter-observer variation reduction. And it has made a big impact on staging, like in lung cancer and many other cancers. Okay, it is something like which is must or a very excellent one-stop stop for staging or seeing the extent of the disease. Coming back to the clinical target volume, there is a funny thing which I tell sometimes. It's like an iceberg. So the tip of the iceberg, which is down, and when you see much below the iceberg, it is much more bigger than the gross tumor area or a small tip what you see. And for in my mind, the complexity and understanding the CTV is from CTV to PTV is something like factor of 10. So let's say GTV factor is 1, CTV is 10 and the PTV is something like 100. But we have to master this. Okay. So as I was saying, you see the CTV, the size has increased. But it is what we are seeing through the pathological microscope in surgical series or non-surgical series. I'll give you one comparison only, okay? Not going in much detail about it. Let's say a lung cancer tumor, which is now my favorite nowadays. So Grills and Corsier, in another paper, what they did was measured the tumor size who underwent surgery, and they chop few millimeters. So what they saw, the microscopic extension of a disease between the different grades and histology also. So what they could make it something like almost at 9 mm, 90% of all the tumor microscopic extension in 99% of the time you will be covering when you are taking something like 12 mm. So what I'm trying to say, if you take a lung tumor of a reasonable size, and if you draw a CTV envelope of nearly 12 mm, you will be reasonably assured that you have taken care of all the microvascular, microscopic disease around it. Okay? But it is histology sensitive also. Like in the old time, this bronchoalveolar carcinoma, now it's part of the adenocarcinoma. The microscopic extension was much, much more. Okay? So we need to be careful when we are drawing our CTV or when we are delineating our CTV, even with the expansion, what is the histology? Similarly, in head neck cancer, whenever it is a stage-wise, the different levels of nodal involvement, contralateral whether to be taken or no. So nice guidelines of the extent of CTV has been given by Gregoire and so many others in different cancer sites. So we need to follow those guidelines. Even recently, for the primary in head neck cancer, they have come up with the guidelines. And they have learned, Gregoire and the whole colleagues across the globe have learned how to involve, if you really want to make a big impact globally in, like, let's say in head neck cancer, you have to make certain rules, set of rules or guidelines. Even like places like TMH are the part in this guideline, right? So that the whole world has an impact to come up with the better results for the treatment of their patients. So everybody has to follow those guidelines diligently for the CTV, for the primary as well as node. And believe me, CTV, the physics colleagues are smart. They say that I can give you precisely at 5 millimeter, this sharp dose fall off. But this is one of the weakest link of the medicine. So we need to have a good imaging, good understanding of biology of the disease, histology of the disease, the extent of the disease to mark our clinical target volumes. So 62 now gave another concept, what we called as internal target volume. And believe me, this is one of the most fascinating picture of a radiation, literature. And if we dwell only on this picture for few hours, we can deliberate it so well. And this picture has shown so many beautiful things. So to make the story very short and brief, what we see is the GTV subclinical disease, or what For a CTV, we add an internal margin. And if we add a setup margin in something like just go on adding, it becomes so big, not a smart idea to treat. Okay. So we need to devise some mathematical models so that we can reduce the setup margin. Even with some form of interventions, can we still further reduce this setup margin? Okay. And since the whole radiotherapy is in fractions, okay, what is the impact of this moving area of the target? Okay. So that it has a physiological function. So like I am breathing, so everything inside the lungs are breathing. So in some patient, if there is a tumor, it is also breathing with, it is moving with the breathing, okay? Or if it is near the heart, it is moving along with the motions of the heart. Or like in prostate, or like in cervix, okay? Or like in upper GI tumors, even in esophagus in the lower third area. Even the spinal cord, there are oscillatory movements. So all these are the part of the internal margin, which we need to add to make a CTV. And when we add this some form of setup margin, which are the technical challenges of a machine, lasers, immobilization devices, so we need to have a planning target volume. Okay, so I'll come back to that shortly. So what we need to do is we need to reduce the setup variation. How we can do this, reduce the setup variation? Good QA of the laser, good immobilization devices. Okay, we need to do image guidance. You can have a simple EPID consistently done to reduce and understand what is the setup of margin so that it has an impact. And believe me, any systematic error will have 2 point more than twice, if you see the Stroom's formula, it is 2 systematic error plus 0.7 random error. So if I can reduce a systematic error, I will be able to have a good precision as well as accuracy is always there, when you have done it with a good imaging. So for me, what is my PTV margin guidance? You may use any recipe. There are a couple of recipes like Stroom's, etc., etc. But you have to do, we all have to do end-to-end verification. Means from scanning to complete delivery, understand what is the margin required. So we have to generate for like head neck system, like headrest, immobilization, daily setup, laser, how we are seeing the ODI, and everything we need to have to generate our own margin. And it is also very important what type of site it is there in head neck or in lung. What technique we are going to use, okay? So the margin may change a little bit here and there. Also, so whenever you are making your own understanding of those margin, you have to critically see that you have not done any marginal failure. So you have to see your own uh, patterns of failure so that you have to minimize or you have to make a zero marginal failures. You need to watch out for the regression pattern. Was there is any edema? So the PTV has come off the skin or it has shrunken dramatically, or in lung, if there is a pleural effusion which has happened and pushed the target area. So critically, you have to see everything to decide upon your PTV margin. So there are many resources, additional resources and guidelines are available how to draw, okay? And please make sure that you use them for your better understanding, okay? And lastly, I wanted to say something. So nowadays, many of the modern things, there are some atlas-based auto segmentation. So these are the segmentation done by the expert okay, and uncontoured image, and they refer as atlas, okay, among the different organs, different shapes, and they represent anatomical variations also. So what it does is basically various shapes have been there, they have been registered, and then they transfer this whole contours on a new image. There is a big library, but what you need to understand, there are many uncertainties also. So whenever you want to use this atlas base, or what we say as ABAS, you need to see each patient that it has been done correctly or not. You have to generate your own library, own model, that it is fitting in your group of patients or not. Okay, so there are a number of Mirada and so many are available right now. So I've just enlisted some of them. Okay, most of the modern vendors have that, but even if you take them, you apply to your segmentation, but make sure that you have your own model and it is aptly applied before you just blindly use it. So coming to the end, I think we need to reduce and cope with this uncertainty and variation. And most important, how understand the biology of the disease, good imaging, follow the guidelines of the rules, and most important, what I say also is follow your patients, see where they have failed, train yourself, retrain yourself, attend this training workshop, and the whole process will be there only after continuous learning. My acknowledgements to Naveen, my teachers, colleagues, and most important to you all for sparing the time to listen to me. I will welcome all my comments, some reviews, whatever critical it may be, on my email, and which I have shown first. And thank you again. And I wish you all the very best for the quiz and other lectures. Thank you very much.